So these are the passive accessory tests in prone. So the purpose of these tests is to look at two things. One, we're assessing the mobility of each individual segment versus a physiologic range of motion where you're having them touch their toes or bend into extension. You're looking at the whole motion of the spine. This is designed to try to isolate each individual vertebrae to understand if the pain is being generated from a particular vertebrae and where to direct your manual therapy. And then also to assess the amount of motion at each individual segment. So the reliability of these tests can be in question if we were to look at inter-tester agreement of which segment is the problematic segment if we were just assessing this for mobility. So that's where the pain response is really the most important piece, because that is much more reliable to agree upon in just saying, is this painful or is this not? The other part where the reliability can be in question is the grade of mobilization. So we're going to start these tests at a grade 1, and that's important because if a grade 1 produces pain, it becomes highly diagnostic for a pain-dominant response, not a mechanical response. So you always want to start with a grade 1 and get a symptom response, and that there can be some disagreement of what is a grade 1 when you look at one examiner to the other. But you want to start with pre-mechanical stimulus. And then if there's no effect, then you go to a grade 2, and then a grade 3, and then a grade 4 if you need to. And you would do that at one segment before moving on to the next segment. So you can start, at the upper or the lower lumbar, doesn't really matter. I think it's, most of these problems are going to be lower lumbar problems, and so usually we start there. So, to find the L5 segment, you can use the iliac crest and come straight across and find the inner space, the spinous process inner space, to represent the L4-5 segment. And then you would just drop down one to find your L5. You're using the hypothenar eminence for this. So, you want to put that directly over the spinous process. And then to create some stability, you want to cup your mobilizing hand to create some stability there. And then you want to put your sternum, your chest, directly over the spinous process. So for your own body mechanics, if the patient's neck allows them to be in a rotated position, I would say, let's have you scoot closer to me. And then if their head can turn, if they can't turn their head, their neck is too stiff or painful or something, and you have to use a cutout in the table, then you might need to lean over a little bit. But for my own body mechanics, the closer the patient is to you, the better my position is going to be to directly be right over that spinous process. So I get my hypothenar over L5. I stabilize my hand. I want to fully extend my elbows because the force application is not through my arms. It is through the dropping of my body weight. So you want to be strong in your position. You're creating a strong triangle here. Elbows are locked. My scapula are almost protracted a little bit. And so now I'm in a really strong position to push. So I get into position, and I'm going to start again with this really light grade 1 force as I ask the patient if there's any pain with this. If there isn't, then I'm going to go to more of a grade 2, where now I am starting to create motion, but I'm certainly not challenging the end range yet. I'm not looking at hypomobility yet. I'm just looking at, again, a symptom response. A grade 2, is still going to be considered a little bit more of a pain-dominant response. If they don't have any pain with a grade 2, then you're wanting to go to end range. You're wanting to reach a limit where if I'm putting, heavy force on the vertebrae and I'm not feeling additional movement. This is where now I shift towards, does this feel hyper or hypomobile? And again, what is the pain response? Is this a stiff segment, a hypomobile segment? A patient that has got stiffness at grade 3 and pain at grade 3 would be considered a mechanical response. for a hypomobile segment. Somebody that feels like, wow, there's a lot of motion there. I'm not sure I'm really appreciating a full end feel, and pain shows up at that grade 3. You might be thinking about a functional instability, somebody that needs core stabilization, possibly. So I do that at L5, and then I move up and I repeat the same process at L4, L3, L2, so on and so forth. Now, you're naturally going to notice less motion as you get to that thoracolumbar junction, as the, that T12, L1, and the vertebrae start to change shape a little bit. The rib starts coming into play. Naturally, you'll probably feel a little less motion up here than you will down in the lower lumbar segments. But it's the same process that you're going to go through for each of those vertebrae to get those two pieces of information: hypomobility, pain response, and then helping you understand this is a mechanical response or more of a nervous system pain dominant response. As part of the passive accessory exam, we're also going to do a unilateral accessory technique. So this, in some schools of thought, would be called a PAUVP, posterior to anterior univertebral vertebral pressure. So you're just putting pressure on over the transverse process. So, after you've completed your PACVP, the central vertebral pressure, if commonly people have a one-sided problem. They just have pain on the left or the right side of their back. Maybe they got symptoms that just go down one extremity. And so you'll need to assess both sides just to get more information, especially if your central vertebral pressures were negative, they're not reproducing a symptom. Commonly, when you go to the site of symptoms, that will recreate a concordant pain. So this is performed similarly to the central vertebral pressures in the sense that you can start by using the iliac crest to find the inner space between L4 and L5, and then just drop below to get on L5. So if you're on the spinous process, then you would just move over directly over to the transverse process and apply the pressure there. So to demonstrate that technique, if I'm on the transverse process of L4 on the left, here's the spinous process, and because the transverse processes, their anatomy is just directly lateral, you can move right over to the paraspinal. And this technique usually is used as an assessment. Usually you're using your thumb just because it's more point specific. So I like to use one thumb for the contact. I place the other thumb on top just so you're not having to use one thumb as hard. It's just easier on your body if you've got both thumbs applying pressure downward, but it's just a direct P to A, posterior to anterior pressure. And similar to the central vertebral pressure, you're going to start with a low grade of force. Grade 1 force, so if the symptoms are present at grade 1, diagnostically, it helps you to understand that this is more of a nervous system dominant, a pain dominant response versus a mechanical response. So you start with your light pressure. Certainly a grade 1, if that was painful, you wouldn't be able to rule out muscular pain because you're just pushing right through the paraspinal. So, you'd have to consider that as well. So this is almost a palpatory test as well, because if you're applying pressure just over the muscle and you have not engaged the joint yet, and the patient is reporting pain, right then you could just do some muscular palpation just to see if those paraspinals are hypertonic on that side. If they are, you're kind of doing two tests at once. But certainly as you start to apply a deeper pressure, where you start to engage the joint, now you're trying to assess the mobility in that segment and a symptom response. Now, if you are going to use this as a manual therapy technique, some schools of thought will use the thumbs as the mobilizing force. Others will use the pisiform instead of the thumb, similar to the hand placement of the central vertebral pressure, where you're using the hypothenar and you're using both hands to create a nice stable structure to push right through the spinous process, you can just shift over. The pisiform can be over the transverse process. I can grip with my hand here, and then I'm going to lean so my chest is directly over my hand, and I can apply that unilateral force directly over the transverse process and mobilize just that one side. Just a quick clinical pearl, this could be somebody that has a rotation dysfunction, where if you checked range of motion, it looked like they had a restricted rotation to one direction. Maybe they had a restricted side glide or side bend to one side. Their symptoms are on one side. Symptoms are not reproduced centrally, but they're reproduced unilaterally. That would be a cluster of findings that would suggest somebody that might need a unilateral technique.